Today's speaker is Dr. David Ashkin. Dr. Ashkin is the medical director and co-principal investigator for the Southeastern National Tuberculosis Center. As the current medical director of the Florida Department of Health's TB program, Dr. Ashkin is responsible for the medical management of all Florida's TB patients, including those most complex cases, which are hospitalized at the state's 2 contracted TB units. Dr. Ashkin is a board-certified pulmonologist and intensivist who trained at St. Luke's Roosevelt Hospital in New York during their outbreak of multi-drug-resistant tuberculosis and did his pulmonary fellowship at the University of Miami during their outbreak. He has published extensively on the care and treatment of tuberculosis. Dr. Ashkin also served on Florida and national advisory panels for controlling tuberculosis and was instrumental in restructuring the Florida TB program, Florida TB System of Care, to better address TB elimination in the state. Dr. Ashkin is currently on the faculty of the pulmonary departments at the University of Miami, University of Florida, as well as Nova Southeastern Medical Institutions. Today's moderator is Connie Haley, Dr. Connie Haley. Connie is an infectious diseases physician trained at Vanderbilt University. She has worked in TB since 2001 and currently works as a medical consultant for the SNTC. I will now turn it over to our presenter, Dr. Ashkin.
Hey, thank you, Linda. Thank you very, very much, and it's a pleasure being with all you guys today. So Linda scared me there for a second. I think during the presentation, she said I'd be talking about human trafficking. I hope not, and if anybody did join for about human trafficking, I got a disappointment. But, you know, I got to say that even if somebody's joined today to hear about me speak about hepatitis C, I probably will disappoint there too, because, you know, I have to say it's a little awkward. You know, I don't know about you guys, but, you know, for us, for a lot of us who speak, you know, I was thinking when I was putting all this together, you know, usually the first thing they make us start to talk about is our disclosures, you know, that we have nothing to disclose, you know. But, you know, when I was thinking about putting this together, I realized that I really need a disclaimer because I'm going to be talking about hepatitis C and tuberculosis. And as Linda said, I'm a pulmonologist. So here's my disclaimer. I am not an infectious disease physician. I wanted to be one. I wasn't good enough. I mean, this is just my, you know, being a pulmonologist was the closest I could get, you know. But I got to say to you that I'm here to talk about hepatitis C and TB. I mean, you know, I think my pulmonary colleagues are going to throw me out. But why would I be talking about it? And I have to say, it all starts. I mean, I really have had an involvement with hepatitis C and TB for quite some time. So I don't know about you guys, but when I was training on Friday afternoons, we always had what we called liver rounds. And, you know, liver rounds was another way of just saying that a group of people were getting together to share adult beverages to unwind, you know. And it was started while I was training in New York City. And interestingly enough, and I don't know why it is, that most people who participate in liver rounds tend to be gastroenterologists, and most of them are hepatologists. I think for me it was a little, it helped me out because it made me feel a little better as I was destroying my own liver. But the bottom line is that I really made some really close friends with people who actually went on to be gastroenterologists and hepatologists. In particular, two of my colleagues, two of my friends, were Dave Bernstein and Tony Albanese, and they both were studying gastroenterology and came with me to Miami. And they, at the time, were studying with Dr. Schiff, and Dr. Schiff, as some of you may know, really was the person who was instrumental in finding hepatitis C, because in the late 80s, we didn't know about hepatitis C. All we knew about is non-A, non-B. There was hepatitis A, hepatitis B, and then non-A, non-B. And that's where the story starts for me, at least, because as a pulmonologist, that's all I knew about hepatitis. But when I took the job at A.G. Holly in early 1993, one of the first things I recognized was something that was very distressing to me, which is that when I started giving patients their meds, about 25% of the patients I was dealing with at A.G. Holly developed drug-induced hepatitis. And it was blowing me away because I was definitely not an expert in hepatitis. I was definitely not an expert in liver, but I realized very early on that, something was happening, and I just really, couldn't figure it out. Why so many? And the first thing I always did was blame my pharmacologist and blame the state that we were buying cheap, TB drugs. But what happened was, once that became an issue, I really started to think about it more, and we started to investigate it more. And what happened, this is the actual first case I'd like to present to you. It's the first case actually at AG Holly that I ever had to really deal with this. And these are the original slides, and it was one of the first lectures and first studies we had ever done. This was a 45-year-old gentleman with alcohol use. He had been diagnosed with TB back actually a year before, in 1992, and he'd actually been inpatient at AG Holly for over 6 months. And what happened is baseline liver function tests were normal. He was started on INA for rifampin, ethambutol, and PZA. This was his original X-ray, and I do want to show you this is really true. This is June 14th, 1993. This is really soon after I started, and you could see here that on the left he had this what looked like loculated pleural effusion with probably some pleural fibrosis, maybe some little bit of scarring here in the right upper lobe. You can see it on lateral. And what happened was they started him on therapy, and this kept happening now for 6 months while he was there. They kept starting him on therapy, and every time they started him on therapy, his AST, his ALT, and his total bilirubin kept going up. He had to keep stopping it. Many of these episodes, he was icteric, he was febrile, he had an enlarged tender liver, and the first thing that happened is, we started working him up to try to figure out what's going on. Sure enough, he had an enlarged liver, he had a normal gallbladder, and his ducts and pancreas were also normal. We went ahead and I started discussing the case with my colleagues because I definitely didn't know what to do with this guy. And this guy wanted to just be on medications. He wanted to go home. And I discussed the case with my colleagues at the University of Miami. And they had told me that the Dr. Schiff was working on a new virus. So you called it hepatitis C. And one thing I like about hepatologists, they're almost as, first of all, anybody knows gastroenterologists and hepatologists, everything is related to food. I mean, that's all they ever talk about. And secondly, that they're almost as inventive as us pulmonologists in the sense that they came up with a new virus, and what did they call it? They called it hepatitis C. And sure enough, his lab, and it wasn't even yet federal, FDA approved, his lab actually had the test, the antibody test, and the fellow said, hey, look, we'll be willing to work with you. Why don't you send this guy's blood to us? And sure enough, we tested him, and he was positive for hepatitis C, which was, again, brand new. His HIV tests were negative, and they even went ahead and they were able to actually look at the RNA in his blood, and it was also positive. We didn't have quantitation or anything else. We just knew he was truly positive for this new thing of hepatitis C. And the question came down to, is great, it's fantastic. What do you do? So again, what did Einstein say about insanity? Just keep doing the same thing over and over again, and expect different results. That's insanity, and that's what I kept doing. And every time we did it, it would come back up. And so the question was, what now? What now? So again, being stuck in this situation, I went to the people who knew, because as a pulmonologist, I clearly didn't know. So I went to my friends, and before we go there, I always, have been using this case for quite some time, as it was the first of these cases we did. This is what I would usually ask you guys, and it's our first question. So what would you do now? Would you restart INH and use rifabutin instead of rifampin and continue treating despite the elevated liver function test and his symptoms? Or don't use INH and rifabutin and just use a liver-sparing regimen like ethambutol and quinolone for 18 months. And I do want to tell you that was not an acceptable regimen for me. He did not want to be there for 18 months. Or a concept that at the time was brand new. Maybe we should treat the hepatitis C and then try to reintroduce the rifabutin and ethambutol. So can we put that up and see what people are voting for? And I got to tell you, I am so corny. At the time when I did these slides, and again, this is probably 1995, PowerPoint was a new thing. So I actually put music into it. So I'm going to actually show you that I can actually do music. I can't do it now, but this is the original, sound effects, as corny as can possibly be. So, Connie, what does it look like on the polls?
That's a good question. They had me muted, so they must not want me to join in your discussion. But what I'm seeing right now is that about 75% want to treat the hepatitis C.
I love the way they think. I love the way they think. They're obviously not pulmonologists, because when I heard this thing, treat hepatitis C, what are you talking about? And that is great. So, that was kind of what we were thinking about. But at the time, we didn't even know what hepatitis C was, but there was some reports actually early on that with non-A, non-B, you may be able to use interferon. And that's exactly what we did. We went ahead and we did a liver biopsy. It showed active inflammation, cirrhosis. But interestingly enough, it was a portal triaditis. It was much more consistent with hepatitis C damage than it was drug-induced damage. So this was a classic, bridging fibrosis with portal triaditis. So it really looked like, hepatitis C, and that's when we biopsied him first. And that's what we did. We used alpha interferon at the time, and sure enough, his liver enzymes normalized. We were able to reintroduce rifabutin and ethambutol, and yes, you'll see, we really had no other problems. This is, again, an original graph from the original cases. And as you can see, initially, before we did the alpha interferon here, his liver enzymes and his total bilirubin kept going up. But once we saw the alpha interferon, you could see it went back down pretty much to normal. We were able to reintroduce rifabutin and ethambutol, and we were able to treat him. And this is actually his chest x-ray. As you can see, some of that pleural fluid and fibrosis got better. And what this eventually did was lead to the first paper, our first paper, and the first paper that looked at hepatitis C with TB drug-induced hepatotoxicity. And the group of us went back and we started doing this on a routine basis as a treatment protocol, and then went ahead and started to look at what the data showed. And we'll talk about that in a second. So what I'd like to do today is, as a lowly pulmonologist, and please be gentle with me, be kind. Again, I can't even spell the hepatitis C. So where are we with hepatitis C worldwide? So the World Health Organization estimates about 71 million people globally have chronic hepatitis C. And that's about 400,000 people annually die from hepatitis C. And most of the people who die from hepatitis C usually die from cirrhosis or hepatocellular carcinoma. If you look back in 2016, the total number of deaths by all viral hepatitis, including, from viral hepatitis, liver cancer, acute cancer, cirrhosis that are related to viral hepatitis, and I'm talking about all viral hepatitis, hepatitis A, B, C, E, and D, accounted for 1.34 million deaths, which actually makes it the leading cause of death from any group of infectious diseases. I know all you being TB people, and we are all TB people, we always talk about TB is the leading cause of death from any single infectious agent. And as you can see, though, it doesn't really matter. These diseases really are making a major impact in the world. So I'd like to ask another question right now. So what do you think right now? Are you seeing more cases than, of hepatitis C and TB, or are you seeing less, or you're not seeing any? So Connie, let's open up the polls one more time and see what are people doing. So I want to get kind of an idea. These questions, I have to be honest with you, are very selfish. I want to see what's happening with you guys, And so Connie, first of all, thank you guys for voting. This is the coolest thing. If it was up to me, I would just open the mics and we'd all talk at once. I guess that wouldn't be productive, but pretty much how I handle everything else in my life. So if we're looking, Connie, if I'm correct.
Yeah, what I'm seeing is that more patients the majority of people are seeing more than they saw 5 years ago, but there's still about 35% of patients that have never seen a patient with hepatitis C in one of their TB patients. And I think that's really something interesting we might want to talk about later when we get to the Q&A part.
Yeah, no, and I agree. And I think this is perfect. And that's exactly why I asked this question. I'm going to show you that you guys, as always, are totally right, because it all depends. And when it's really interesting, just look at the hepatitis C in the United States. About 2 million people in the United States are estimated to have chronic hepatitis C infection. We'll talk about that. And that's about 2% of the population are infected, have a positive hepatitis C antibody, But as we'll talk about, not all people who have a positive antibody actually have disease, because some of them are actually able to clear it. But most people can't. So when you look at the 2% of people who have a positive hepatitis C antibody, about 75% of those people actually have the hepatitis C RNA in their blood, meaning they have chronic hepatitis. And what you guys are seeing is exactly what's going on. You nailed it. What happened is that, when we started recognizing that non-A, non-B was being spread in the blood, and when we started to have the beginnings of testing, they actually started testing the blood. And, and that started in 1992. And as soon after starting the testing of the blood, what happened is the number of cases and the incidence of TB in the United States fell. And again, it was mainly because we cut off the major way TB was being transmitted, which was through blood transfusions or blood product transfusions. But as many of you are alluding to, and you know better, over the last 10 years, things have really changed. And the number of cases that actually start to increase. Matter of fact, the incidence is triple. And why is that? Because of other things that are going on. When we talk about of all the issues our patients with TB have, TB is the least, as you guys have heard about, and obviously you're very well aware of. The opiate crisis and the increased use of intravenous drugs again have really fueled the hepatitis C epidemic. And if you look at where it's most of the hepatitis C occurring, just like you guys are seeing why there was such a dichotomy, 9 states have over 50% of all the cases, and that's California, New York, Michigan, Texas, Pennsylvania, Tennessee, Florida, and Ohio. But as you guys know, it's not only affecting them, but we're seeing it mainly in the West and the Appalachian regions. And again, where the opioid crisis is hitting hard, that's where we're seeing it. In other places, we're not. And that's I think why we started dichotomy. And this is a map, and I think you'd agree, if I put up a map of TB, it would be very similar. And that's why these two epidemics are really pretty much running together. I think the big difference, again, is our Appalachian regions here, which again, you're seeing, a higher incidence because of the drug problems, the opioid problems we're seeing there. One of the things, if you look about hepatitis C, and this slide's a little old, but it's still there, that most of our hepatitis C cases are patients over the age of 35. And I do want to remind you, especially those of you who have gray hair, like I do, if you remember, and this is where, we explain, remember, we always talk about when we gave INH, that patients over 35 were more at risk. And again, some people have questioned that maybe the reason for that wasn't necessarily a change in liver, like some people said. Some people said as we got older, our liver wasn't able to process it better. A lot of people have looked at the possibilities that there were many of these patients who were also co-infected with hepatitis C. And so how is hepatitis C transmitted? And it's mainly a bloodborne transmission. In the United States, it's mainly among IV drug abusers. It's the leading risk factor for hepatitis C right now. Much less common. It's sexually transmitted, and it's rare among heterosexuals, more among our homosexual population, and also healthcare workers. And you can also get it by tattooing, sharing razors, acupuncture. Maternal fetal is extremely, extremely rare. Breastfeeding is not associated with it. But, casual contact in the household is also not associated, but 10% of patients have no risk factors that they could find. So it's mainly a blood-borne, transmission. So what is the hepatitis C virus? And again, please be kind to me. I am a pulmonologist. There's no alveoli here, but so hepatitis C is a positive. It's an RNA-stranded virus. It's a single-stranded. It's the positive sense. I wouldn't worry about that at all. And essentially, what happens with hepatitis C is that just like HIV, it's an RNA virus. It's very simple. And what it does is that it brings its RNA in and then allows our body, it makes our body make copies of itself. And it takes over our body. So real quick, what happens here, as you can see from this drawing, is the virus binds to the membrane. Once it binds to the membrane, it gets pretty much encapsulated in into our cells. Again, our cells can't kill it. So what the virus actually does, it actually fuses with the membrane of the lysosome, and it actually then gets extruded into the cytoplasm. Once it's in the cytoplasm, this RNA is released. And once the RNA is released, Interestingly enough, our body turns the RNA into a protein. It's a large protein chain, and part of this protein chain is structural proteins, meaning the proteins that make up the virus, but more importantly, it also brings in proteins that are the enzymes which make more of itself. And that's what we're really going to be targeting. So when we talk about drugs in a little while, it's going to be in this process. Once the proteins are cleaved into their parts, they actually form what's called a membranous web. This complex actually starts taking RNA that's there and making more RNA, making more protein. It then gets cleaved again, it gets assembled, and then gets extruded. And as we'll talk about in a couple minutes, we're going to take advantage of some of these unique processes to use drugs to try to stop it. So what happens once you're infected with hepatitis C? Interestingly enough, there's about 20, if you look about 15 to 40% of patients who are infected with hepatitis C, meaning it gets in their blood, will actually not replicate. They'll be able to clear the hepatitis C from their blood. But the vast majority of people can't. And what they will continue to do is they'll continue to make hepatitis C RNA. Of the people who do have hepatitis C RNA in their blood, about 20 to 50% will go on to cirrhosis. Of the people who go into cirrhosis, about 20% of them will develop liver cancer, or 20% will go into hepatic failure. And then, unfortunately, the only treatment at that point would be transplant. And this occurs over 20 to 30 years. But things like alcohol abuse or using drugs that also interfere with the liver can actually accelerate this process tremendously. And that's why, again, drinking and hepatitis C is a really bad combination. The key for us as TB people and for everybody else is that most of these patients are totally asymptomatic until the end. They don't know they have hepatitis C. The vast majority, 56%, are asymptomatic. Only about 35 to 40% of patients actually have symptoms. And when they do have symptoms, the biggest symptom is fatigue. And I think one of the things that behoove us and where I hear all the time is that the vast majority of people who do have hepatitis C, their liver enzymes are normal. Let me repeat that, because I think that is the surprising part. I hear all the time, I don't understand. We started his drugs. His hepatitis C his AST and ALT were normal. We didn't take hepatitis C. And understandable, because as you can see, about 42% of people will actually always have a normal ALT, which is the enzyme that's most sensitive, or at least most specific, I should say, to the liver. 42% will have a persistently normal ALT, even if they're hepatitis C positive. Another 43% will have intermittent elevation. So you may have caught the person when they were normal. We start the TB therapy, and then suddenly their LFTs go up. We, of course, blame it on the TB drugs, and it really wasn't. It was just a normal pattern of hepatitis C. And about 15% will have elevated ALT persistently all the time. And this is what I want to show you, because we talk about this all the time, and I want to put it in perspective of the TB patient, that most patients who have hepatitis C have what we call the sine wave pattern of ALT, meaning the ALT just normally goes up and goes down, goes up and goes down, goes up and goes down. And notice it does that over months. So imagine this is the TB patient. We start them on TB meds right here. Everything looks great. We're like, hey, everything's great. But after a month or so, suddenly the LFTs go up. And we're like, oh my goodness, look, the LFTs are up. It must be the TB drug. Stop the TB drugs. And that happens all the time. And then they go, and once we stop the TB drugs, as you know, what happens is, wow, it gets better. But then it gets worse again. And again, so I think you got to be careful that, just because you have an elevation does not mean necessarily it's always the TB drug, So how do we diagnose TB, hepatitis C? Usually the hepatitis C antibody, and that's the most common. As we talked about, though, just because your hepatitis C antibody is positive doesn't mean you necessarily have chronic hepatitis C, and so that's why we go ahead and we check after that to see if you have the RNA of the hepatitis C in your blood. And not only do we check if you have the RNA, but we also check for what's called the genotype. There's 7 different genotypes of hepatitis C, and there's a bunch of subtypes. And from a TB perspective, to be 100% honest with you, it's not all that important. But the key point is that the different drugs are seen in different countries. The different hepatitis C genotypes are seen in different countries. and also the treatments are somewhat different. Some of them are harder to treat than others. But the bottom line is now is that the United States Preventive Service Task Force is advocating a one-time screening for all persons born between 1945 and 1965. And again, as I showed you, because of the before that time, if you look at when people would have gotten blood transfusions and stuff, it's all based on the change in the blood supply in 1992. So when we look at the guidelines, who do they recommend, not only for people born between 1945 and 65, but the Infectious Disease Society also adds to the United States Preventive Screening Task Force, and they also recommend at least one-time screening for patients who use IV drugs, including people who just used it once, because all it takes is one time. People who use intranasal cocaine or illicit drugs, people on long-term hemodialysis, people who got stuck by needles, including people who got tattoos or piercing, healthcare workers, like we talked about, who may have been stuck, children born to infected mothers. Again, we say that it's relatively rare, but it still can happen. People who were ever incarcerated, people who, again, got blood components before 1992 or clotting factors before 1987, people who are HIV positive, people who are sexually active, but they're about to start the pre-exposure prophylaxis for HIV, and we'll talk about a little about that, why in a second. Unexplained chronic liver disease or cirrhosis that you're trying to figure out what happened, and in our case, people are starting to get hepatitis from the TB drugs, we probably should check to make sure there's nothing else. And people who solid organ donors. So why am I giving you this list? Because the bottom line comes down to, if you look at TB patients, and if I gave you a chart of who should we screen for TB, there's a lot of overlap. So these two groups have a lot in common as far as their quote-unquote risk factors that make you at risk not only for hepatitis C, but also risk for TB. So, I don't know, last night I was with my daughter, and, every so often she gives me, why do I care? And why do I care? Why should I care about that? So I ask you, so why do we care about hepatitis C in the TB community? Why should it bother us? So I wanted to just give you some studies and some what I think is why we need to know a little about it. So if you look at just what is the prevalence of hepatitis C among patients who have tuberculosis, in general, there's been a recent study that was looked at. It was a meta-analysis. They looked at all studies that looked at what the prevalence of hepatitis C was around the world in patients among TB patients. And I want to emphasize again, this is all over the world, so it's going to be a lot of variations. But there was actually 21 studies that have been published that met the criteria of TB patients who were screened, pretty much uniformly for hepatitis C. And overall, this meta-analysis showed that the prevalence of hepatitis C was about 7% of TB patients are co-infected with hepatitis C. So, not insignificant, And I think what's more important, the first thing that kind of got me interested in this when we talked back then is, is there more of a link? Is it not just risk factors, but is there something about hepatitis C that actually may increase your risk of developing active disease? We always talk about that 1/3 of the world is infected with TB, but only about 5 to 10% in general go from infection to disease. And most of those people who develop active disease have some sort of immunosuppression. So early on, it always struck us, is it possible that hepatitis C is causing some immunosuppression that actually makes it easier for people who are infected with TB to go on to active disease, TB disease? And, there's more and more research that's suggesting that, in fact, that may be true. As a matter of fact, we always knew that if you were a renal transplant patient, if you have renal failure and you needed a transplant, interestingly enough, if you were infected with hepatitis C, you did not need as much immunosuppressive therapy to stop rejection. Matter of fact, many of these patients don't need any immunosuppression to stop the rejection. Now, that's two factors. One is the patients who get renal transplants, in general, they don't need as much immunosuppression to keep the graft as, let's say, heart patients or lung patients. But more studies have really looked at, and sure enough, they found that hepatitis C impairs lymphocyte proliferative responses. And remember, that in TB, we need our lymphocytes, right, to contain the disease. And even as importantly, there's been some studies now that are looking and showing that patients who are hepatitis C positive, actually, some of that hepatitis C has the ability to bind tumor necrosis factor receptors. So they almost become like a tumor necrosis factor blocker. Now, again, they're not nearly as potent as some of the biologics that we're using right now. But I think most of us in the TB world understand when we say the person's on a tumor necrosis factor blocker. I think most of us would automatically turn around and say, uh-oh, if he's infected with TB, you can't watch a TV show anymore without hearing those commercials. Tell your doctor before you start this therapy if you've been infected with TB. So again, I don't want to tell you that if the hepatitis C is as potent as those blockers, but it looks like it does have an effect. And again, some of this also may be that, some reasons why we see more TB and hepatitis C patients may just be the shared risk. But, just to look at that further, there's been a number of recent studies that have come out that have also looked at, what is the associated risk. And there was a nice study done by the VA group here, Veterans Administration group here in the United States. And by looking at all their patients who had TB, they found that there was about almost a threefold increased risk. If you are infected with TB and hepatitis C, you have about almost a 2.7 relative risk increase of going from infection to disease. And there's also been other population studies, especially the one from Taiwan. And as you know, one of the advantages in Taiwan is all their medical records they have a nationalized medical system. And they have a nationalized electronic medical record. So they have the ability to have large databases and to look at different risks. And when they looked at their population, and they looked at patients who were hepatitis C positive, they found about an increased incidence of about 1.5-fold increase of developing active disease. So I do think that there is an association between the two, and I do think this is something that will be looked at more. So what really is the reason? All that's interesting about the immunosuppression, but really, why do we in the TB world, why do we care about hepatitis? Why do we care about, increased liver issues? And the issue is this. All of us in TB all know with the current meds we use, the number one side effect, the number one adverse effect we worry about is what? We worry about hepatitis, drug-induced hepatitis, right? And as you know, it's the most frequent of the severe adverse effects we see from TB meds. It can cause hepatotoxicity. Obviously, we know it also can cause skin reactions, GI, and neurologic. But hepatotoxicity is potentially the most serious of these. And as you know, INH hepatotoxicity is no joke. And up until recently, it was the most commonly implicated agent that led to acute liver failure in the United States. That in Tylenol, and it was the most common reason for adults to require an emergency liver transplant for these idiosyncratic drugs, hepatotoxicity. So that's why we always treat all of our TB meds with respect when it comes to the liver. As all of you know, when you look at the TB drugs, about 20% of patients who we start on INH, rifampin, ethambutol, and PZA will have an increase in their AST or ALT. The vast majority, these 20% are asymptomatic. They'll have an increase. It's usually less than 3 times normal, and it really has no effect. They're asymptomatic, and it usually goes away on its own. It usually occurs, the asymptomatic ones occur right after starting therapy, and they usually resolve on their own. But if you look at toxic reactions, meaning reactions that are more than 3 times the normal, most of them, 60%, occur in the first 3 months. So it's usually soon after starting therapy. But as you know, you can get these kind of reactions anytime up to therapy, and 80% of, another 20% of these drug-induced hepatitis will occur for the first time after the first 3 months. And as all you know, if you look at what are the signs and symptoms of drug-induced hepatotoxicity, especially serious, usually it's starting to get abdominal pain, nausea, vomiting. You even may turn jaundiced, But, even though you have these symptoms, it really doesn't tell you what's causing it. It just tells you that we need to look, closer, and obviously we need to confirm it with laboratory monitoring, Most of these cases, as you know, and that's why we always monitor, when we talk about monitoring, our TB patients for hepatotoxicity, the number one form of monitoring is history. We always tell our patients that if you start developing nausea, vomiting, abdominal pain, to tell us immediately. And the reason, as you know, is that most of these symptoms, if you stop the meds, will resolve on their own and they get better. And more importantly, we also know, unfortunately, that if you continue the meds in the face of these symptoms, if it is truly a drug-induced hepatotoxicity, that many of these patients can go on to hepatophilia. And that's why we always talk about, as soon as you get these symptoms, to tell your medical professional, and that we need to assess it further, So when we look at, what is the incidence of anti-tuberculosis drug-induced hepatotoxicity, meaning, how often does this occur with RIPE? It really varies. It occurs anywhere between 2 and 28%. And again, what we're looking at is patients who have a significant enough increase that we have to either change or stop the regimen. And what is the definition for anti-tuberculosis drug-induced hepatotoxicity, like we talked about? It's any increase in serum ALT. Remember, we use the ALT because the ALT is much more specific to the liver. Remember, the AST, even though it's more sensitive, meaning that, it may pick up more cases of damage to liver, it's not specific, meaning you can see an elevated AST from breakdown of your muscle, if you drink too much alcohol. You can see it if you have, muscle problems, heart attacks, organ issues. So the ALT is more specific. And if you have an increase of more than 3 to 5 times, and as you know, usually we stop the meds if it's 3 times with symptoms or if it's greater than 5 times without symptoms. And those are usually the definitions for drug-induced hepatotoxicity. And when it comes to total bilirubin, we usually say anything above the upper limit of normal would be considered drug-induced hepatotoxicity. But here's my message, and it's something that we go around talking about all the time. Don't always blame the drugs. It is something that we see, with the Southeast National TB, Center. When we do our medical consultations, one of the most common questions we get, is elevated LFTs, what do I do? And I think the most important thing is to remember that drug-induced liver disease is a clinical diagnosis of exclusion. Meaning you can't say it's drug-induced hepatotoxicity unless you exclude other reasons, So, I want to always remember, don't always blame the drugs, Think about other things. Usually when somebody has an elevation of their LFTs, what we want to do is we want to do a sonogram. We want to make sure there's no gallstones, there's no liver disease, no masses. I do want to remind people that of a syndrome that you can see quite often, and especially in patients who have an elevation of their total bilirubin and the AST and ALT are normal, is something called Gilbert syndrome. And Gilbert syndrome is just a genetic predisposition to having difficulty conjugating your bilirubin. It's absolutely, normal. But what the key point is, you'll see an elevation of the total bilirubin with no elevation of AST or ALT. And the key is that it will almost all be indirect bilirubin or unconjugated bilirubin. So if you see a total bilirubin, I'm just making something up, of 1.5, and then the direct bilirubin is 0.1, meaning almost all indirect, right? And the person's asymptomatic and they have no elevation of their LFTs, their AST or ALT, that's probably Gilbert syndrome, and it's totally, it's benign, but it affects about 5 to 10% of the population. And interestingly enough, in the general population, how do they diagnose Gilbert syndrome? They give them 900 milligrams of rifampin. So essentially what we're doing is a mass screening among our TB patients, screening for Gilbert syndrome. But so that's why I think we see it a little. It's just something to know about, and there's really nothing else to do. Obviously, we also want to make sure our patients are not taking alcohol or any other medications that may be affecting the liver, such as, taking Tylenol, or, we obviously our lipid-lowering drugs or statins, or, we also want to make sure. And that way we do that is, history. I want to remind everybody one trick way of knowing if somebody may be drinking is when their AST to ALT ratio is more than 2 to 1. Again, that could also happen with muscle breakdown. But whenever you see that, start thinking about your patient may be drinking. And obviously what we usually do in those cases, we do a drug screen. And then Lastly, I think in these kind of cases of viral hepatitis is usually indicated, and the reason is most of our patients, as I showed, have risk factors to hepatitis C. So we usually do a viral hepatitis whenever we see, the elevation, and obviously some rare patients will have other conditions like autoimmune or pregnancy, but that's usually, based on the history. But again, why do we need to make sure it's nothing else? Well, first of all, we want to make sure we're not missing anything and that we're treating whatever the patient may have. But as importantly is, I see this all the time. Everybody talks about drug resistance. When you're in the TB world, all of us are constantly talking about MDR, XDR, pre-XDR. It's what we talk about. But in reality, I challenge you, and I know the numbers haven't been done, but I think we all agree, there's a bigger problem we have than MDR or XDR is what I call virtual drug resistance. And what virtual drug resistance is, the patient starts itching, the doctor stops the rifampin. The patient's LFTs go up, the doctor stops the rifampin. The patient, whatever, everything is always stopped the rifampin. And remember, when we stop the rifampin, we just essentially just cause drug resistance. The patient's treated like drug resistance. So I just would say to you that I think it's really important to make sure we rule out these other causes, because if we don't, we have to treat these patients longer and with weaker drugs. So to get back to the story, so one of the unique things about the paper we did, and we'll talk about it, is we looked at what was this association between hepatitis C and TB, drug-induced hepatotoxicity among our TB patients. And this goes back to 1998. It was done over that 5-year period. And as you can see, what we showed is that if you're hepatitis C positive, your risk of developing a drug-induced hepatitis, meaning an elevation of your LFTs or total bilirubin, was more significant. And if you're HIV positive, your chance of developing drug-induced hepatitis was increased. But here's the key. What we did is we tried to actually look at, how much. So if you're hepatitis C positive, your chance of getting drug-induced hepatitis was about a 5-fold increased risk. So like we talked about, if your risk, let's say, normally, like we said, is anywhere from, 2% to about, they said 28%, but it's usually about 2 to 7%. If you're hepatitis C positive, your chance of developing drug-induced hepatitis is anywhere from 10 to 35%. If you're HIV positive, you have a 4-fold increased risk, and this was the key. What we saw in our population has been noted afterwards. If you're HIV positive and hepatitis C positive, your risk of developing drug-induced hepatitis was 14-fold increase. So that's where we saw it the most. But it's not, since the study came out, there's been at least 4 other large studies that have looked at the association, and they've also confirmed that there looks like there is an association between hepatitis C and drug-induced TB hepatitis. But, because of the commonality and, and how often we have to deal with increased liver function tests, back now, almost around more than 10 years ago, the ATS came out with a statement of how to handle hepatotoxicity that's caused by TB drugs. And, they always give you this long flow chart, which I really, really like. I think it's really fantastic. And the basic part is that if the person starts having, first of all, normally, always identify before you start the TB meds. Risk factors, if they have risk factors, go ahead and check for their AST, ALT, and then what we do is we monitor them, and if suddenly their AST, ALT goes up more than 5 times, they talk about holding the meds, as we'll talk about in a second. If it's not going up, we just continue the treatment. If they're symptomatic, we hold the meds, and then once we hold the meds, then they talk about doing the workup for the hepatitis A, B, and C. I do want to show you something that's interesting. They don't tell you what to do once you have the workup. They just kind of tell you check for it, and we'll talk about that more. The other thing they talk about is maybe what you should do is once you hold the meds, then reevaluate, and then once they're back to normal, start rifampin. Some people say rifampin and ethambutol. Personally, as we'll talk about in a second, I like to talk about rifabutin instead. Rifabutin is a drug that, as you guys know, has just as much effect against tuberculosis, but has less effect in the liver, and we find at least that we have less hepatotoxicity in situations like this. One of the things I'd like to talk about, and we'll go over, but I just want to talk about this chart. They say once a person on rifampin and ethambutol, go ahead and add INH. This is one of those places where I personally disagree with this. And the reason is that PZA is a key drug in the treatment of TB. It's the drug that shortens us from 9 months down to 6 months. And I do understand that if you look at all the TB medications, PZA is the one that probably causes the most hepatotoxicity. In a meta-analysis done in Canada, they showed that about 6% of patients who got PZA had an elevation of LFTs, which is about twice either INH or rifampin. But here's the issue. What we don't know is it really just a PZA sub or in combination? And personally, if you ask me, what I like to do is once I get the person back on risperidone and ethambutol, if they've gotten less than 6 months of therapy, I personally like to use PZA if I can. And again, this way it shortens the therapy, because if you have somebody with liver disease, I want to get them off of TB meds as quick as I possibly can. So that's a little bit of a little bit of a preference difference. But then obviously they also talk about it. Yes, please.
This is Connie. You told me to interrupt you if I needed to. You said 6 months. Did you mean 6 weeks? If they've had less than 6 weeks of meds, get them back on PZA, not less than 6 months?
No, I apologize. What I meant is if they've gotten, thank you. If they've gotten less than 2 months of PZA, I'm sorry about that. If they got less than 2 months of PZA, we want to put them back on PZA. If they've already completed their initial PZA regimen, they don't need PZA. Thank you, Connie. Thank you for clarifying that. Thanks. What I was saying is about 6 months is that I'd like to use PZA so I can shorten the therapy down to 6 months. If I don't use PZA, now I'm talking about at least 9 months of therapy. And then lastly, on this chart, like we were saying, is that sometimes we want to use other drugs that don't affect the liver, what we call liver-sparing agents. And those liver-sparing agents are drugs that work against tuberculosis but have little effect in the liver. And those are things like fluoroquinolones, ethambutol, cycloserine, and the aminoglycosides. And sometimes when we can't reintroduce any of those medications, any of the first-line TB meds, those meds are the ones we fall to in order to try to complete therapy. Linezolid also has minimal effect in the liver. So what's my approach when I'm faced with somebody who has elevated LFTs who's on TB meds? First is rule out other causes, like we talked about. And in addition to everything else, I'm a biased person. I also like to do drug levels. I like to make sure that that the one of the reasons that we may be getting hepatotoxic is that our levels are too high. So I like to do it, but that's somewhat controversial. Not everybody has access to drug levels. Obviously, the other thing I like to do initially is to make sure now with molecular techniques that the person doesn't have any resistance. And I like to do that early because I think you'd agree I'd hate to be treating with INH and getting INH hepatotoxicity only to find out that the person has INH resistance. And then the next thing that we need to do is we need to know how sick is that person. If that person has just been diagnosed with TB and is really sick, having fevers, weight loss, is 3, 4 plus positive and is sick, I think we need drugs. So, I don't like to just automatically stop all meds. What I like to do is I'll stop the ripe, but I may continue with medications that are liver sparing, like levaquin, ethambutol, an aminoglycoside, So I do think that one of the things that you really need to, assess early on is I think you need to assess how sick the person is. Most of our TB patients, luckily, are not that sick, and you can hold the meds and they're fine. But rarely, especially in our immunosuppressed individuals, especially in patients who are on tumor necrosis factor blockers or HIV positive, who have disseminated disease, especially in the brain, we can't stop meds. We need to use meds, but use meds that are liver sparing. And then what we do at this point is even if we either use meds or don't, we allow the transaminases to return to normal baseline. And then what I like to do at that point is try to determine which drug caused the issue. And remember something to remember that INH and PZA usually cause an elevation of the transaminases. They usually cause transaminases, I should say. They usually cause an elevation of AST or ALT. While rifampin usually causes an elevation of the total bilirubin, what we call cholestatic. But the reason I like to do that is at least I can know what medication do I expect to have a problem. Now, I have to admit to you, I'm still going to always reintroduce the rifamycin first. And the reason I reintroduce the rifamycin first is because that's the drug that shortens me down from 18 months to at least 9 months. And again, I usually like to use rifabutin personally. I want to be upfront. The data behind that is very, very limited, but we have good response to rifabutin. And then once we use, like we talked about, if it's elevated transaminases, once we use rifabutin, we determine if the patient still needs PZA, and then we stop the PZA after 2 months. Like I said, we try to make sure there's no resistance. And personally, if I'm having trouble with the LFTs, I try not to use INH, at least initially, and try to get through rifabutin, ethambutol, PZA. And the reason is, remember, rifabutin, ethambutol, PZA can cure people for 6 months in the vast majority of cases. Some people, like with INH-resistant disease, likes to add a quinolone, and again, that's okay because levaquin or levofloxacin, right, has no effects in the liver. So unlike Moxie, which has a small amount, right, a lot of us would use levo in that situation and then treat with at least the first 2 months until we're off of PZA. And then after we stop the PZA, some people may want to add INH. Another little trick that you can do in these kind of cases where you have increased LFTs and you need to try to get people back is to use intermittent therapy. And remember, 3 times a week therapy for many patients, especially those who are smear negative, who don't have extensive disease like cavities, can get by with 3 times a week. And some studies suggest that there may be less toxicity, And in the vast majority of these cases where the transaminases are elevated, this approach works. We don't even have to treat the hepatitis C if it's there. Just a little variation. What if it's the total bilirubin that's elevated? Again, if it's the total bilirubin that's elevated, again, it's more likely to be rifampin. But again, you want to make sure there's nothing else that's causing this. And again, when you do a sonogram, one of the drugs I like to use if I do see some sludge in the gallbladder, and I think there may be a little bit of gallstones there, but the person's too sick or doesn't need surgery, is ursodiol or Actigol, which is the drug that they use to break down gallstones. But interestingly enough, it's also been shown to be liver protective. And we've had a number of patients where if you can add that, it actually will help you in these situations. And then as we talked about, if it is total bilirubin that's elevated, that's one of the more common scenarios, just like, for hepatitis C. So we check it. We've already talked about the Gilbert syndrome. And then, as we talked about, one of the things is if all that fails and you keep reintroducing the drugs and the LFTs keep going up and the person's hepatitis C positive, it's time to start to consider therapy for hepatitis C. And that's what we did in our study, and that's what made the original study, I thought, pretty interesting, is not only did we show the association, but we then also went ahead and we did biopsies of the liver, and we treated the hepatitis C. And at the time, we treated with alpha interferon. There was 4 patients, and in all 4 patients, the patients had elevated LFTs. No matter how much we did that scenario I just talked about, the LFTs kept going up, would be challenged. And what we did is we did the liver biopsy, showed a portal triaditis, which was consistent with hepatitis C. We went ahead and used the alpha interferon, and sure enough, all of them had a reduction to normal LFTs. And when we repeated the liver biopsy, the portal triaditis had gotten better. And just to remind everybody, that was early on, but alpha interferon in combination with ribavirin, which came out a little later, really was not bad. It actually didn't cure everybody, but it at least could suppress the virus and actually kind of suppress it enough so that we could reintroduce the TB meds successfully to cure the TB. But unfortunately, we still stuck with the hepatitis C at the end of it. And that's where everything has changed. And that's why I think we're in a really exciting time right now when it comes to hepatitis C. As you guys are aware, over the last 5 years, there's an explosion of hepatitis C drugs. As a matter of fact, it's very close right now, which is great, but you can't watch TV anymore without hearing about biologic agents, the new cancer agents, the PD-1, the programmed death, inhibitors, or hepatitis C treatments. And these hepatitis C treatments are really exciting. As you know, they're what's called direct-acting antiviral agents. What they literally do is they, as we will talk about, is they interfere with the replication of the virus and essentially kill it. And what's really exciting is that you can now get cure, meaning persistent viral response, or what we call sustained viral response, after 8 to 12 weeks of therapy. If you check these people 12 weeks after they complete the therapy, we're seeing cure rates where there's no virus in the blood in 90 to 95% of patients. It's so exciting. And not only does it get rid of the hepatitis C, but it's also looking like that we're getting a decreased rate of cirrhosis and carcinoma. It is very exciting. And this is a list of the new drugs, and it's growing literally by the month. You're seeing protease inhibitors, that we'll talk about the NS5A inhibitors and polymerase inhibitors, which we'll go over. And just real quick, remember what I was telling you before, what happens is once the RNA gets in, remember what happens, the RNA gets transcribed into a protein, and that protein contains both the structural proteins as well as the enzymes that it needs, and it's a protease that cuts it. So those protease inhibitors, they work by stopping the virus from being able to cleave its protein. And then once the proteins are cleaved, as we said, it makes that membranous web, and that membranous web starts making, replicating the RNA as well as making protein. And there's two ways that it stops it. There's two other drugs, the other pathways. One is a polymerase inhibitor, and what the polymerase inhibitor does, it stops the RNA from being able to make more RNA, almost like our reverse transcriptase inhibitors and non-nukes and nukes, And what also, there's another class of drugs that are called the NS5A inhibitors. They stop the membranous this membranous web from being able to make more virus. So these are, three different pathways. There's more coming. There's fusion inhibitors, just like HIV, that are coming out. So we're going to have more and more of these drugs. And what the advantage is just like with HIV, they work at more than one site, and it's the same principle. You try to use at least two drugs that work at different sites, so you totally cut off the replication. And now the Infectious Disease Society of America, the American Association of the Study of Liver Disease, they've all gotten together. They now have hepatitis C guidelines on how to treat it, diagnose it. You can get it on your phone. And they even have charts, as you can see, using the different combinations for how long would you use it, and also, versus the different genotypes. So it's really, really nice. It looks so good. The only bad part about it right now is that even though it looks good, it's not so cheap. As you can see, these regimens can cost anywhere from $13,000 up to over $30,000. Obviously, with time, these prices will come down, but they are quite expensive right now. So I guess let's stop for 1 second, and we're getting close to the end here, but how about right now? Have you guys ever treated somebody with hepatitis C in a patient with active TB? So this gives me a chance to take a drink of my coffee right now. Connie, are you still there?
Yeah, it looks like your webinar will be very beneficial to the majority of our audience. I think with about half the audience voting, 80% or more have never treated a patient with TB and hepatitis C.
And that's okay. In fact, I think that's how it should stay. Again, as we'll talk about, the vast majority of patients with hepatitis C, you can get through without having to deal with it. But, what these webinars are always about is what do you do just in case you can't get through it. So I agree. I'm glad to see the vast majority have not, And so, I'm sorry, just 1 second. So why haven't they? Why? It's all so fantastic. Why haven't we used it more? Why isn't every one of our TB conferences, why aren't they all being sponsored by hepatitis C companies, right? And the reason is this, that, it's always, rifampin. It's always rifampin. Everything's rifampin. And what does rifampin do? As you guys know, rifampin is an inducer. It increases the metabolism of any drug that's processed in the CY3A, the CYP3A enzyme in the liver, what we call the P450 system. And look, every drug, for the most part, is metabolized there, which means if you use rifampin with any of these drugs or any of the rifamycins with any of these drugs, what happens is the hepatitis C drug will be metabolized at an increased rate, meaning that it will be broken down so there's not enough to kill the virus. And if by some means, let's say in certain drugs, where, like if you look at Latent, even if it's not the CYP3A, rifampin also stimulates the P glycoprotein. And what it does then is it actually, again, excretes more of the drugs. And just real quickly, because this is just a refresher, a reminder. So the P glycoprotein, as you remember, sits in the wall of the intestine and also in the biliary tract. And what it does, it literally will take the hepatitis C drugs and pump them out of the blood and put them back into the intestine, and you poop them out. Or it'll take the drug out of the liver and put it in the bile, and you excrete it out, so you have less in your blood. So rifampin induces that and causes more of the drug to come out of your blood. And as we talked about before, in the liver, the CYP3A4 will actually increase the metabolism of these drugs. So interestingly enough, by being a strong inducer of both of these enzymes, it causes a decreased level of the hepatitis C drugs, which cause them to be ineffective, and one of our concerns are actually may make them lead to resistance to hepatitis C. And every one of these new direct antiviral agents are reported to have a severe or major interaction with the rifamycins, especially rifampin, and they're not recommended to be used together. In fact, there's 13 cases of TB that have been reported in patients receiving interferon. Again, interferon is different. It's not a direct antiviral, but it does suppress both the hepatitis C and also suppress the immune system. And these patients actually developed TB while they were on the hepatitis C, and in many of these cases, the doctors tried to continue using the DAAs, the hepatitis C drugs, and all of them had a failure of their hepatitis C drug. So rifampin very strongly does induce the metabolism enough that these drugs don't work when we're using rifampin. So great. So Dave, great lecture there, Dave. You told us, you made us all excited, and nothing, like always, nothing. So what do? So we have a couple options. So if you do have somebody with hepatitis C and TB in 2019, the first is don't treat the hepatitis C and do those little tricks we talked about before, using rifabutin, stopping INH, and in most cases it works. In most cases it works, Most patients, you can get through the TB therapy, and then once you complete the TB therapy, then you treat the hepatitis C. Almost all recommendations suggest you treat the TB first, almost if you can, But what happens if you can't treat the TB because you have elevated LFTs? Well, one of the things is don't use a rifamycin. But as we talked about it, in the TB world, you don't use a rifamycin. That's like making some of the MDR. You may have to treat for 12 to 18 months, though let's be upfront. You, in fact, could theoretically treat without a rifamycin until, for 12 weeks, until you cure the hepatitis C, and then add the rifamycin later. And again, that's a possibility. It just hasn't been proven, but it's definitely an alternative. The other thing is what we do. We usually just use interferon and ribavirin if we have to, meaning if we tried all the other things and the LFTs remained elevated, we'll just go to interferon and ribavirin, and it suppresses it. We treat for 6 months, and then what we do afterwards is treat with the hepatitis C with the direct antivirals. And then I think the future is, and I really do think this is the future, just like the HIV drugs, is eventually we'll have drug levels, and we'll be able to adjust the hepatitis C drugs based on the rifamycins and get the right levels in order to treat them both. And I do think that's what we'll be talking in another 2 years. Right now, to the best of my knowledge, I just checked recently, there's no commercial lab that's offering hepatitis C antiviral drug levels. I believe that will change. So real quickly, so we talked about TB disease. What about hepatitis C and LTBI? Something I think most people see all the time. Interestingly enough, when they did a meta-analysis, there did not seem to be an increased risk of INH-induced LTBI, meaning that even if you had somebody who was hepatitis C positive, if you treated with INH, it did not appear there was an increased risk. And again, the numbers may have been small, but so far there's no indication not to treat somebody's LTBI because of hepatitis C. But, one of the things I do want to point out is that remember that 3-HP has less hepatotoxicity. So a lot of people are saying, if you do have somebody who has liver disease or hepatitis C, you may be better off, treating with 3-HP. And there's a study there that showed that, in fact, when they looked at 3-HP and INH, patients who got 3-HP and who were hepatitis C positive did not have an increased risk of hepatotoxicity. And again, most people are recommending that if you are going to start somebody on hepatitis C and therapy, and they have LTBI, many people are recommending that you treat the LTBI before the hepatitis C therapy. And then lastly, the last question comes about hepatitis C. So should we be screening our patients who we're about to treat for hepatitis C? Should we screen them for LTBI? And again, there are some indications that in parts of the world especially that it may be beneficial because there are a number of cases of patients who are treated with hepatitis C that got LTBI. But right now, there is no recommendations. And in almost all those cases, they don't think it was the drugs that actually caused the breakdown, but many of these patients had other conditions that probably increased risk, like diabetes or cirrhosis or interferon. So with that, where are we? And I think to summarize, hepatitis C incidence is on the rise again, and the concomitant, presentation of hepatitis C and TB presents some challenges to all of us. Most times TB therapy, as you guys know, is generally well tolerated, but toxicity occurs. If the side effects toxicity appear, I think we need to initiate a very methodical diagnostic evaluation and then treat accordingly. And then if the DIA, if the drug-induced hepatitis is thought secondary to hepatitis C, I think you can carefully reinitiate the TB meds, but I can't emphasize enough. Give us a call, get expert help, and then treatment for hepatitis C in patients with TB disease is evolving. Stay tuned. And these are some resources, and then our hotline, and then lastly, Connie and everybody else. Thank you guys for allowing a pulmonologist. Connie, how do you feel about yourself? A pulmonologist to talk about hepatitis C. So with that, thank you very, very much, and let's open it up for some questions. So, Connie, thanks.
So, Dave, this is Connie. First of all, I do not discriminate based on your board certification. I merely choose the person that I think will be the most amazing speaker for the topic. And I think your presentation certainly proved me right. That was really, really amazing. I do see some questions, and I'm going to get to them. I'd like to encourage people to please type in the questions box more questions. We've still got a good 22 minutes to pick Dr. Ashkin's brain. But Dave, one thing I want to go back to, because you and I get a lot of consults, and this is not an uncommon challenge that we have, which is why we felt it was appropriate for our webinar series, When TB is the Least of Their Worries. You presented your patient who came into AG Holly, was diagnosed with TB and hepatitis C, started regular therapy, and I want to reinforce the point you made, which is that if you know at baseline they have hepatitis C and you've screened them with labs appropriately and you see that their liver enzymes are fairly reasonable, then you go ahead and start 4-drug therapy. At what point do you challenge, so say that patient gets started on 4-drug therapy and develops, a 3 to 5 times increase of liver enzymes. I want to tie in that graph you showed where the sine wave increase in ALT shows that sort of the natural history of hepatitis C is that those enzymes are going to go up. So in some patients, could you re-challenge those same 4 drugs and see how, or re-challenge patients and see how they do? And when do you instead go straight to managing hepatitis C? Did that make sense?
What a great question.
I just want to be really
what an absolutely great question, Connie. And so I'm going to go back to my first slide, which is, remember, I'm not an infectious disease physician. And what I mean by that is this. My primary goal is to cure their TB. So I think this is going to change. Personally, when I'm treating someone with hepatitis C and TB, my first goal is to treat the TB and cure them of TB, and then turn it over to you to treat the hepatitis C. So I have to be honest with you. Right now, I'm trying everything possible not to add other drugs that make you sick. So I have to be upfront with you. Taking pegylated interferon is not fun. You get a flu-like symptom. You have to get an injection. The pegylated is better than it used to be. With ribavirin, you can get, pancytopenia and stuff. So personally, I try to use the treatment of hepatitis C, as my last resort. I'll do everything possible up until treating them longer, to be honest with you, to try to get them back on their TB meds. And then if that fails, then I'll do the hepatitis C. And again, I'll treat with alpha-interferon. But notice, I'm not trying to cure them of hepatitis C. I think that's going to change. I think it all changes real soon when we have the ability to treat them both together with effective drugs, just like HIV. And if I may, early on, again, showing my, unfortunately, my gray hair, which, unfortunately, my hair, I have a lot of it. And, but, back when it was HIV, initially we used to treat with 3 nukes. And that was like unbelievably like, what's the matter with you? Like, why would you treat with 3 nukes? And if you remember early on, we couldn't use the protease inhibitors with the TB meds. And again, what I was treating at that point with 3 nukes was really not to cure somebody, not that we can cure, but not to get total suppression of the HIV, but to get it down low enough so that I can improve the immune system and still treat the TB. Obviously, with the introduction of drugs that did not get affected by erythromycins, like some of our integrase inhibitors and some of our non-nukes, what's happened is that it's changed our approach. And I believe it's going to change our approach when either we get drugs that don't interfere or drugs that we can use, drug levels to use them both together. And I think at that point, we'd really start, like you're saying, to think about curing both diseases. But right now, I have to be honest with you again. I have a pulmonologist focus, which, as you know, being a pulmonologist, we have no focus. But all I'm thinking about is the TB and how do I get the person through TB treatment and then shift it over. What do you think, Connie? I don't know if everybody has that approach, but it's kind of where, yeah. Mm-hmm.
So my thoughts are, what you're talking about is really looking at each patient individually, which is the approach we're using now in TB care, that individualized patient approach. And the other thing is, if you're trying to manage 2 diseases and you're having challenges, so you've tried to reintroduce the rifampin, ethambutol, and INH to PZA to no avail, you end up looking at, I think you're saying you keep trying to get a regimen until you end up having to treat the patient without rifampin. And right. I want to highlight again the importance of rifabutin as an option if people can afford it in their clinic, find it in their clinics. But I think including the patient in those discussions is also part of that patient-centered care.
Correct.
And one other thought I have is that many of our providers are local health departments and not really supported with big budgets. And so certainly, we may not be able to get access to interferon and ribavirin, but I would say reach out and try to work with local gastroenterologists or others to see if that can be done. And if you find yourself getting to a point where you're not going to be able to use rifamycin, you're looking at long treatment of these patients, or if you do want to try to use the ribavirin and interferon yourself, reach out to your centers of excellence. And as you can see, Dr. Ashkin is certainly the expert in our region, and I'm sure he'd be glad to help providers even outside our region. So 1-800-4TB-INFO is our number, and our sister TB Centers of Excellence, I don't know their phone numbers offhand, but they're on the CDC website or their own websites. Dave, several questions have come in now, which is great. You're talking about treating active TB and hepatitis C and prioritizing the TB first. When you're talking about latent TB infection, one of the questions is, so which do you prioritize at that time? Is the hepatitis C, if the patient sort of got a chronic, active infection without a lot of elevated liver enzymes, do you prioritize treating that first? Do you prioritize treating the LTBI and then turning to the hepatitis C? Do you treat them together with either INH or 3HP? So what would be your sort of order of operations in that situation?
Yeah, what a great question. Thanks. So again, same thing. I think it's really about the patient, and you make a great point about including the patient, Connie, and I want to thank you for that. And the same thing, I mean, if you have a patient, I think you agree, who is otherwise healthy and having elevated LFTs, I think the priority in that situation should be the hepatitis C. So I think a lot of people would say, hey, treat the hepatitis C, you know, and especially if you're going to not use interferon, because again, the other direct antiviral medications do not look like they have an effect on the immune system. So you're okay using it. You're not going to lower the person's immune system and cause the TB to come out. So most people would say, you know, you go there. But on the other hand, let me give you an example. Let's say you have somebody who has, let's say, you know, is somebody who has a LTBI, hepatitis C, and unfortunately, let's make it really bad. And, you know, they have like, you know, bad psoriasis, and now they have to go on a biologic agent. And, you know, there is the interference with the biologic hepatitis C. But a lot of people would say in that situation, you probably want to treat the TB first and then go over. But again, we're still evolving here. But I think it's really the patient, you know, and what's the problem that's causing the issue. You know, the beautiful part now is that as we're getting shorter and shorter with our preventive therapies for TB and hepatitis C, it's becoming less of an issue because we can do it relatively fast. And neither disease is an acute disease for the most part. They're both pretty chronic. Patients have been having these problems for a long time. So, you know, now with 3-HP, you're down to 3 months. I think we'd agree we're probably, hopefully real soon, you know, with a regimen that may even be as low as a month, you know, I think that will also change things. But I think at the end of the day, you need to base it on what's going on with the patient. Most people would recommend avoiding both, though, treating both together if you don't have to.
And I also wanted to highlight, just because, as I mentioned, you and I have had several patients that we've done this on. Well, it sounds very daunting. We talked about the side effects of the interferon, and we also know that ribavirin can have side effects. You have successfully treated a number of patients with those drugs, and while they may be a challenge, most of those patients have tolerated it pretty well, and you've been able to safely cure their TB, and then at the end of therapy, turn them over for the newer, more curative hepatitis C treatments. I mean, you've had, you know, side effects aside, most of those patients you actually have managed pretty successfully. Is that correct?
Yeah. Yeah, we end up, I would say, you know, between, you know, the case we have in Florida in our region, we probably end up treating maybe 3 or 4 patients a year with alpha interferon. So we're not talking a lot. And on the other hand, in a big number, I mean, we easily treat, I mean, in the state of Florida, you know, we easily treat, I would say, 40, 50 patients with TB that are hepatitis C positive a year, and that doesn't include outside. And the vast majority, again, I want to emphasize, we don't need to use alpha interferon. But when we do use it, it's been very successful. And you talk about cost, and that is something to think about. But I would also like to factor in, which is usually what we factor in, is 18 months of therapy without the rifamycin. So, you know, there is a cost in the alpha interferon. The costs are coming down. But, you know, there is also a cost of prolonging therapy. But, yeah, we use it about 3 or 4 times a year. But I have to be honest with you. I'd be lying to you. I'm really, like, all excited. We're right now trying to gain more access to the drug levels, because ultimately I think that's the way it's going to go. Yeah, it doesn't pay to use suppressive drugs.
Yes, great. Well, there's a comment here, which I'm glad to see. In Delaware, one of our participants has had really good success treating hepatitis C first and then treating for LTBI. So that's good news. Some of the comments are talking about if you get to a patient who you've tried everything and you just cannot use the rifamycins. Someone is asking about, what do you think about using bedaquiline? Well, actually, this question is, I think I jumped a little bit to a conclusion. The question is, what do you think about clinicians using bedaquiline in MDR patients with untreated Hep C, like Child-Pugh Class B? And then I did see another question about liver-sparing regimens, avoiding injectables, and, you know, so.
I mean, I think the bedaquiline question is a really, really good one. You know, and again, bedaquiline can cause some liver toxicity, but as we've seen, it's not nearly the numbers we see with rifampin or PCA. It's great. I don't know. I don't think we have those kind of numbers yet. As we also know, this whole talk may become a moot point real soon, right? I mean, as new regimens come out and with the prospects of, they're now tested like in the next study where they're using bedaquiline, delamidid, and linezolid for 6 months, there's a potential that we don't need erythromycin. And I think that's out there. And that's why I wrote in 2019, that's what we're doing. I'm not so sure that's what we're going to be doing in 2020 or 2021. I think as more and more data comes out, and these are great questions, I think it's going to change. But can I stop for a second and a shout out to my TB community, all the TB nerds out there, what a great day to talk about new drugs and new options. I don't know about you, 10 years ago, we would never be talking about new drugs and new options in TB. So, again, stay tuned. I think all this is changing, and these are great, great questions. What do we do? Do we really need an aminoglycoside as a liver sparing? And, can we use other options? This is amazing, and it's a cool time to be a TB person because for a long time, we had nothing new. So great questions. I don't have the answer. I don't know.
Someone was asking about other MDR TB drugs that are hepatotoxic, and specifically linezolid.
Right. So linezolid, people always talk about, I think the biggest problem with linezolid is the dosing. And I think that's the problem, personally, and I know this is not what we're here for today, and I know I'm going to get into trouble. But the biggest problem with linezolid is the dosing. We're still using dosing that's used for bacteriology, for staph and stuff. And if you look at the MICs for most bacteria for linezolid, it's much, much higher than TB. The MIC of linezolid for TB is very low in most cases. You don't need the same doses, and most of the toxicities comes from from the dosing. So I don't have proof for this. I can't show you a study, that says that you do. But I think most of us in TB are using much, much lower doses of linezolid than we did just 2 or 3 years ago, with much better success. And I can honestly tell you, I don't know of a case of linezolid-associated hepatotoxicity in one of our MDR cases recently. Mm-hmm. So I agree with you. It's such a good question, but I think that the devil's in the details. I think that's true of linezolid in general, that a lot of stuff we talk about is the dosing. And again, as you know, like tadalafil, may also be even more of a, and there's a couple other, sister agents that may have less mitochondrial issues. So I think it's exciting. I think it's, I think it's something to, that's going to be changing too. But again, I caution about linezolid and making sure that we talk about the dosing.
Great. Thank you, Dave. One of our participants, Dr. Khan in Alabama, wanted you to clarify.
I don't want to, no. Ed is banned from these things, so there will be no Ed questions. Go on next, please.
Go ahead.
Let's be nice. Let's be nice.
Whatever he wants, because I believe Ed is a pulmonologist and an ID doc, an overachiever for sure. But he wants to know. I think he wants you to clarify. You were talking about cholestasis and uricediol and rifampin, but I think his point is that if you have rifampin-induced cholestasis and it's fairly benign, you can continue the rifamycin. And again, It's kind of getting to that point that wherever possible, we try to maintain the rifamycins. And so, can you kind of clarify a patient who gets an ultrasound and you see sludge, their bilirubin is mildly up or not terribly up, versus the patient who might have, increasing significant bilirubin, and how you'd manage those with rifampin or without?
Yeah, I think this question is coming from Ed's pulmonary side because it's a really good question. If it was coming from his ID background, I think this would be a rotten question. But I agree with Ed, and Ed said the key word, if it's benign. There's patients who just have an elevation of their total bilirubin, but are otherwise asymptomatic, that true liver function, we always talk about liver function, but we really don't mean liver function, we mean transaminase elevation. But their true liver function, as long as their INR is okay, as long as, their albumin is good, there's no sign. Ed is right. We may push it a little further, but we watch them very, very closely. Most of the cholestasis we see from rifampin, as Ed is pointing out, is usually benign. But, when I say benign, it's, let's say the upper limit of normal, and everybody's upper limit of normal for total bilirubin is a little different. So let's say it's 1.5. You usually see minor elevations, and we'll just watch them closely. But if you start getting symptomatic, when a person's turning, true jaundice and is having nausea, vomiting, and signs of liver failure, that's not benign. That needs to be stopped. So I do agree with Ed that there are cases you may push, but I think the key is you got to take the whole patient, and most importantly, watch them closely, monitor them closely. And I can't say that enough. And when I say monitor, I don't mean with LFTs and stuff. I'm talking about it's really important that our nurses, our field staff, the people we really rely on, the true heroes of TB, that every day when they see that patient, they ask how you do. And we encourage the patient to be upfront and forthright with us that, if you're having symptoms, we need to know. So, yeah. But yes, I agree with that.
So that kind of ties into the last question that I was going to ask. When you did the poll about how many patients have ever treated hepatitis C with the TB, 80% said none. And so because many of our participants, and to be honest, probably the linchpin of all of public health and management of TB patients falls to our frontline TB nurses, investigators, right. DOT workers. What advice would you give to someone who encounters a patient, they find that this patient has TB and now hepatitis C as well? What kind of advice or recommendations would you say are important for them? They're obviously not making the treatment decisions, but what guidance would you give them, besides taking a deep breath and not panicking?
No, I think hold your breath. All of our nurses should hold their breath. No, that's not nice. It's nurses. Was nurses, whatever. But hey, I agree with you, Connie. Called linchpins. What I would really just say is I think the most important thing is get help. These cases can really be very, very, very complex, and I think it's very, very important that what we do is when you see this is to get a physician involved or a practitioner involved, and then start looking at the whole case. Number one, how sick is the patient? And that's where our nurses excel. Our nurses are outstanding. They know our patients better than anybody else. They've seen them. They literally live with them. They know. And if the patient's doing poorly, stop everything and definitely get help. As a matter of fact, in many of these cases, if I had to say anything, if you really have a question, send them to the emergency room and let them get evaluated, because these cases in rare situations can go south, fast. But on the other hand, I think the whole key is to get a clinician involved. And if there's any questions, I can't say this enough, call one of the centers or call whoever your consultant is, because one of the nice things, now, or especially over the last couple of years compared to in the past, there's a lot more resources out there to get real-time consultations, either within your programs or, within one of the centers. And it doesn't matter who you go to, as long as there's somebody there to review the case with them, go over all the facts of the patient, and then make a concerted plan to make sure that we address it. So, I agree with you most. I really do believe the frontline, the role of the frontline person, in my opinion, is to identify there may be a problem. And then secondly is to know where to go. Connie, what do you think?
Sorry, I had muted myself. Yeah, absolutely. And if you would, Dave, maybe you could back up 2 slides. I'd like to just show this participants what these resources are that I've put here, but also to reiterate contacting us whenever necessary. We learn from every single case that we get consulted on, and these cases also provide the centers opportunities to teach others as we share them in webinars and local meetings and that kind of thing. So Dave, would you mind backing up to the resource slides here? I think you still have control. Okay, so everyone, we're going to close right after this, but I wanted to go ahead and share with you all some resources that I think will be very, very helpful to you. One is in about, I think it was like 2005 or 6, a really nice statement was put out. And while some of the drugs we use now, like rifabutin and some of the second-line MDR drugs, are not included in this statement, It really has an excellent description of the etiology of hepatotoxicity, how the different drugs work. What do you do when you encounter a patient who has a bump in their enzymes or in their bilirubin? And as you saw, Dr. Ashkin had a really nice slide that showed sort of a flow chart of what do. You pre-screen, you treat, if this happens, then you do this. There's a similar graph for TB and for latent TB infection. So I'd highly recommend that you access that. And I believe that under our handouts is this document by UC Salconen. It looks like it's the year 2012. The other is managing active TB patients at the risk of hepatotoxicity. Heartland has a really nice pocket guide that you can go to. I think that might be something that you could have on your phone or in your pocket when you're seeing patients. I think it's important to be thinking about risk factors with patients. One of Dave's slides did list all the different risk factors, and know that screening is recommended not only for patients born in certain years, but for a lot of those patients who are also at high risk for TB. So, low threshold for obtaining a viral hepatitis panel. There's treatment for treating hepatitis C if you're really into that and have time. There's a really cool hotline I found that actually is clinician-to-clinician advice through the UCSF. And then on the next page of resources, oops, went too far. There's a Q&A guide on the CDC website for professionals, but there's also one for patients and families that you could go to CDC's website and share with patients. A lot of information on CDC's website, some great information about counseling patients. The AIDS education and training centers, which we're closely tied to, have a toolkit with lots of interesting information, both for clinicians and for training purposes. And the other thing is the APHL. I just don't want to lose sight of the fact that labs are our partners, whether it's doing TB testing or hepatitis C testing. So the APHL also has a fact sheet that can help you if you get test results and you're kind of a beginner and trying to figure out what they mean. We are working on the date. I want to close out by, first of all, saying thank you, Dave, so much. You're just an amazing speaker and always so knowledgeable. And I want to thank all our behind-the-scenes SNTC staff who have helped us get this whole series together. Linda, James, and Donna Setzer in particular, who are our techie people that keep Dave and I straight. And then all the rest of our team with the planning. And our next webinar is going to be Dick Brostrom talking about TB and diabetes, which I know will be very, very interesting. And he is very much the expert on that topic. We're shooting for some time in July. So hopefully, if you're on our website's email list, you'll see a notification for that. But if you don't, give us a call and we'll get that to you. This webinar has been recorded. It will be available on our YouTube channel soon. Ultimately, this and others in this series that we've done will be made into products which will enable you to go in on your own time. They'll be made more interactive with some Q&A, some case studies, little quizzes and things so that you can get CME credit or CEU credit down the road. That's a work in progress. It may not be in 2019 that we've got that ready, but it is coming. Last but not least, we hope in the future to talk about TB and TNF-alpha inhibitors, TB and transplant, perhaps TB and mental health, TB and alcohol, maybe some other topics. If you have something that you think is a big challenge, so that taking care of TB is truly the least of the patient's worries, please let us know. We're definitely open to any ideas. And I want to just thank again all of the participants, as well as the team putting this on, and hope that all of you have an absolutely wonderful rest of the month. Thank you for participating.